The really good news is, and I think what we're trying to highlight, is that the hormone sensitive nature, that vernacular, is there for a good reason, which is these are patients that the cancer cells are still acting like they normally would in that they respond to testosterone. Testosterone is really the fuel that feeds prostate cancer, and therefore it can be used to stop the cancer in many cases from growing. So we have a number of treatments that are designed to either restrict the body from making testosterone, and then there are treatments like Erleada, which are designed to block the ability of testosterone to have any effect on the cancer itself. And we can therefore put the cancer into a bit of a dormant phase where it often will stay for years.
Hey everyone, this is Jonathan Marks from Go2 Health. I hope you're doing well today. September is Prostate Cancer Awareness Month. Prostate cancer is the second most common cancer among U.S. men, with an estimated 300,000 men diagnosed with prostate cancer each year. Approximately 15%, or 45,000 of these cases, are metastatic castration-sensitive prostate cancer, a type of hormone-sensitive prostate cancer. We'll explain what that is. While advances in early detection and treatment have improved survival rates, many decisions about care require looking beyond clinical trials to how treatments perform in everyday medical settings. Today, Dr. Benjamin Lowentritt and Bob share what men don't know about this type of prostate cancer and how all cancer data isn't equal, and how patient advocacy can support men along their prostate cancer treatment journey. We're talking today with Dr. Benjamin Lowentritt. He's the Director of Prostate Cancer Services at United Urology Group. He's the Director of the Comprehensive Prostate Cancer Program and Director of Minimally Invasive Surgery and Robotics at Chesapeake Urology. He's been a leader of incorporating advanced prostate cancer treatments into community urology practices. Bob Lane is a prostate cancer survivor and a patient advocate being treated with a Johnson & Johnson prostate cancer medicine, Erleada. He's a volunteer with the SHARE Network, a Johnson & Johnson program made up of people who are dedicated to inspiring others through their personal health journeys and stories of caring. If you're enjoying the show, it would mean the world to us if you took a second to leave a 5-star review on YouTube or Apple Podcasts or Spotify or wherever you're listening to us. It helps more people find the show and let us know we're on the right track. Thanks in advance. So welcome to the show, Bob Lane and Dr. Ben Lowentritt. How are you guys today?
Doing great, thank you.
Doing great, hope you are.
Good, thank you. So Dr. Lowentritt, what are some of the types of prostate cancer that are lesser known? I didn't know there were different types of prostate cancer. Tell us about those different types.
Yeah, Jonathan, thank you. And I'm really pleased to be here partnered with Johnson & Johnson to talk about what I'll say is a specific kind of subtype of prostate cancer. You're correct in that prostate cancer really is all one disease, but we go through different phases and we see it at different points in the disease. And what we're really focusing on today is what we call the metastatic hormone-sensitive prostate cancer, which is unfortunately for patients that either we didn't find the cancer early enough, so they've presented with cancer that's already spread, or they've had a treatment and the cancer has recurred and spread, and then they have metastatic hormone-sensitive disease. So, we're talking about those patients that are at risk for dying of their prostate cancer, because although the majority of men do very well, there are a subset of patients that are going to progress and unfortunately succumb to the disease. The really good news is, and I think what we're trying to highlight, is that the hormone-sensitive nature, that vernacular, is there for a good reason, which is these are patients that the cancer cells are still acting like they normally would in that they respond to testosterone. Testosterone is really the fuel that feeds prostate cancer, and therefore it can be used to stop the cancer in many cases from growing. So we have a number of treatments that are designed to either restrict the body from making testosterone, and then there are treatments like Erleada, which are designed to block the ability of testosterone to have any effect on the cancer itself. And we can therefore put the cancer into a bit of a dormant phase where it often will stay for years.
And is Erlita a relatively new drug, or has it been around for a while?
Well, I mean, it's relatively new. It's been around though for about 6 years, 6 to 7 years or
Hmm.
so in different uses, but we're having some great experience with it.
Good. And Bob, you have had a remarkable journey surviving prostate cancer. Can you tell us about your journey?
I sure can. Thanks, Jonathan. It started out in 2014 when I was diagnosed with a very high PSA and a biopsy, and they took the prostate out with the radical prostatectomy, the Da Vinci, and had clean margins all around. So everything was positive, but because of how aggressive it was, they said we're going to monitor every 90 days, which they did, and everything was negligible, zero across the board for 3 years, and then zero point zero 0.01, and then 3 months later, zero point zero 0.03, 3 months later, zero point zero 0.07. So we knew it was back, and they put me on finasteride, and we knew right away that it was hormone sensitive, as the doctor just described. So that
Hmm.
was good news. So we watched it grow until it got to the point where they could actually, identify it and locate it and take it out with radiation. And during those 4 years, while we watched it grow, I had plenty of time to look at different alternatives, knowing that it was hormone sensitive. And Erlita that was in 2021, just a couple of years after Erlita hit the market. And
Hmm.
it was obvious that it was working and it was working well. And I'm living proof of that. The nice thing about it is it's 1 or 2 pills a night, every night. And that's the way I basically self-medicate, if you will. And I'm living life well. I'm playing golf and doing all the things that I did before I had it.
Good for you, Bob. Now, you said a critical thing when you first started talking was getting your PSA test done. So tell us about the PSA test. How often do you get your PSA test done?
I get it every 90 days.
Every 90 days. Good.
Because every 90, but I'm unusual, and that's pretty normal. I see the doctor is nodding his head. That's pretty normal for someone who's in a metastatic position with prostate cancer,
Yes.
because we don't want the prostate cancer to get ahead of us. So 90 days is a pretty normal test period for people with prostate, with metastatic cancer that could go back into an aggressive state at any point.
Great. And doctor, if we can come back to you, how often should men get a PSA test if they're not testing for cancer yet? How often should we
Yeah.
get it?
So thanks for coming back to me on this. Right. So what Bob's getting is really we're monitoring his cancer with PSA. It's a very important part of that. But not what we normally are talking about when most men are hearing about PSA.
Right.
So
Yeah.
PSA is also a screening blood test. So what we use to help find prostate cancer. Bob, he actually mentioned it's how his cancer was initially found. And typically that's something that we recommend people getting yearly. Usually I recommend someone get the man get their first test in their 40s so you can establish kind of a baseline, and then probably in your 50s start to do it yearly and carry that through into your 70s as long as you remain in good health. The whole goal is to find, cancer that may be risky well before it becomes risky. If you have special circumstances like a known family history, or if you're African American, we know that there's higher risk there. So we may
Hmm.
adjust the timing of your screening, but typically it's once a year at that point.
Good. And guys, I just want to remind everybody, the way I remember to get my PSA test is I get it every year around my birthday. I make sure the doctor, gives me a test around my birthday so I know that I have a healthy year coming up. So Bob, let me ask you, you go by Elevator Bob. How did you come up with that nickname?
Yeah, not too many people have that kind of a nickname, that kind of a moniker. The head nurse at the urology practice where I am a patient asked me one day if I thought it'd be nice if men coming in had a chance to speak with someone who's been through it, who's been through the surgery, who's been through the radiation, the side effects. I said, yeah, that'd be a nice idea. And she asked me again 12 seconds later, and I said, you're not asking my opinion, apparently. She said, no, I'm not. So I said, yeah. I said, I'm game. So I sit out in the elevator lobby. I'm the only one there. And I have a table with a lot of legitimate prostate cancer information on there, from the basics of what it is and to information on androgen deprivation therapy, which is what I'm on now, the hormone therapy. And if a patient will approach me, because I don't approach any patients, it's too sensitive a topic to
I
be
see.
approached by a stranger, and I'm a stranger to these folks.
Yes.
But if they'll approach me, and we have ways of cajoling them to approach me, then it's a good conversation, and I get them to talk about their diagnosis. A lot of times it's the spouse or the loved one, the daughter, speaking on behalf of the patient, because a lot of men don't want to talk about it. So, okay, I'll deal with whatever's out there as long as I can get help in the hands of the people who might be able to use it. And once I know what their situation is, I'll put together different pieces of information from credible sources you've heard of, whether it's the Mayo Clinic or the Cleveland Clinic or MD Anderson or Memorial Sloan Kettering, and give them information to where they can learn about the disease. I never give them a recommendation on what to do, but I give them information so they can learn and ask their doctors, because that's the key. That's where the rubber hits the road for the patients to actually learn about their disease and learn how to communicate with their doctor. So that's what I do in the elevator.
God bless you for doing that work. I really appreciate that, Bob. So, Dr. Lowentritt, let me ask you, you've authored a number of studies of real-world evidence in prostate cancer care. Now, what is real-world evidence? What are we talking about there?
Yeah, just as the name would suggest, right? This is a way for us to understand more about treatments like Erleada and how they're being used and having effect in real world, everyday clinical medical practices, right? So it's as compared to a traditional clinical trial, which is a very curated and structured process, which is really important to understand the effect of a treatment to get it approved to be able to be used. We also then have the ability, with really the availability now of data, since everyone is always in their computer. If you notice, your medical record is in the computer. It's not pulling out your personal information in any way that would be traceable, but we're able to look at large numbers of patients and see over a whole variety of different settings, of different communities, of different areas of the country, of different racial backgrounds, and start to really understand, are we getting the same kind of results in all of those communities that we expect from the clinical trial, and also start to answer some questions that a clinical trial is just not set up to ask. So we're able to really augment the level of comfort and confidence that people have when they're evaluating different treatments, because you're able to add to that knowledge about a treatment overall, and when your patients are making their decisions.
Right. So let me just tell people where they can go to learn more before we go on. I have a few more questions after this, but if you want to learn more, you can go to Erleada.com, and let me spell that for you. It's ERLEADA. ERLEADA.com, ERLEADA.com. So you can go there to learn more. So let me say and comment to what you've both said. Go to Health is all about evidence-based medicine. And what the doctor was just talking about is, I've talked many times about clinical trials and the clinical trial process, but what the doctor has just underlined here is, with all the data that we now have available to us, you can actually continue to do studies in the field based upon patient data. So it's not just doing a clinical trial under a controlled circumstance. We can now monitor and improve, treatments from real world data, from real people getting treated with different kinds of medications and procedures. So have we found, doctor, that this real world data, does it actually change the medication or the procedures or practices in any way by having this data?
I think every patient is individual, right? So I don't want to make any, broad statements here, but I do think some of the data that we're able to do when patients and doctors are faced with really a number of different options, right? They can use the real world evidence in some ways to help bridge the gap between what those clinical trials have shown and then what you're facing when you have a choice of different treatments and combinations, to choose from. So yes, I do think it's helping inform decisions so people can say, hey, yeah, this is the right option. This is what we're going to do first, or this is the combination we're going to choose, because that's not always clear what the best option may be from just trying to look at different clinical trials and trying to go through it that way. So yes, is it, I'd always want to say is it's not the gold standard like the clinical trials are, but there are a lot of questions that just you're never going to get a clinical trial to answer a specific question that might fit a specific patient. And I do think that real world evidence is helping fill in some of those, voids where we need more information.
Fabulous. Good. So get to my favorite part of the interview, where I get to ask each of you, what question didn't I ask that I should have asked? Or what message would you like to leave people with today? We'll start with you first, Bob. What message would you like to leave with everybody?
The message I'd like to leave would be, if you have a diagnosis, you're not alone. There's 1 out of 8, 1 out of 6, 1 out of 5, depending on what subset you fall within. And if you're already diagnosed, build a support group. Get with your physician team, get with your healthcare providers, get with some fellow prostate cancer patients, get with your families, and share the information among those people, that you're those three different groups, because your families will be a lot more comfortable with it, and you will be too. And if you're not diagnosed, get tested, because getting it early results in a fabulously successful, cure rate.
Yes.
And getting it late is the other side of that coin, and you'd much rather be on the first side. You want to be on the side where it's found early.
Good. Bob, have you been in a support group?
Yes, I have been in support groups.
And
yes,
what are some of the biggest benefits you've received from that?
Why opening people's eyes, opening my eyes to different side effects, different misconceptions, or being able to validate certain thoughts and perspectives. So it's been on the receiving end and on the giving end. So because I know more about prostate cancer than the average bear does, because I've been studying it for 3.5 years.
Yeah.
So I know a little bit more about, so I can give back a little bit in some of those support groups, but I still learn stuff. Every time I talk to patients, I learn something.
Yeah, I'm glad you're saying that, because I think men, we have the habit of trying to go everything alone. And when you're in trouble, you need some help and you need some support. So I'm glad there are support groups for men with prostate cancer. And doctor, what message would you like to leave with people today?
I think your audience is the perfect one to talk to about, but I think being informed is the best thing that I could encourage everyone to do. I think when you get a diagnosis of cancer, right, everyone's mind goes blank. You immediately go into sort of, you probably don't hear half of what's be coming out of your doctor's mouth. So even as a physician, I always try to have multiple conversations about this, but encourage you as a patient to have multiple conversations, to have multiple ears present, bring in your family and your close advisors, to have some of these discussions. And don't be afraid to ask questions. Don't be afraid to seek out specialists if you feel that that's something that you're not getting. Go to resources like Erlita.com and others that have, great information about any treatment you might be considering. I think the real world evidence is an example of say, hey, listen, this is, generally real world evidence actually is answering the particular questions that patients often want to know as well as their doctors. So, look into as much as you can. I know there's limits to what everyone can expect to understand, but there are resources out there that can help you at whatever level of understanding you're trying to achieve as you're making your decision on your treatment, right? These are critical diseases at times, but that still doesn't mean you need to feel like you are helpless, right? So be engaged yourself throughout the process.
Good. Thank you. So remember, you can go to Erlita.com. That's ERLEADA.com. And guys, we want to all encourage you to get your PSA tests done at least once a year. Check with your doctor about when you should get it done. Bob Lane and Ben Lowentritt, thanks for being with us today. It's been great to have you here.
Thanks so much.
Yeah, thank you very much for having me.
We've been talking with Dr. Benjamin Lowentritt. He's the Director of Prostate Cancer Services at United Urology Group, and he's the Director of the Comprehensive Prostate Cancer Care Program and Director of Minimally Invasive Surgery and Robotics at Chesapeake Urology. We've also been talking with Bob Lane, who's a prostate cancer survivor and a patient advocate being treated with Johnson & Johnson's prostate cancer medicine. This has been Jonathan Marks with Go to Health. Remember, as we say at the end of every show, go to health. We'll see you again next time. Take care. Bye. Thanks, guys. That was great.
Hey, thank you. That was wonderful.
Thank you. Enjoyed it. Very well done, Jonathan. Yeah.
Good. Thank you. Thank you for tuning in today to Go to Health. You are one of almost 10,000 people per day who enjoy the evidence-based health information offered by our guest health experts. You can watch us on our website and YouTube and listen to us on 8 podcast networks. Be sure to join Jonathan Marks in our upcoming shows each week. If you like our show, please share this episode with your friends and colleagues. You can subscribe to the show, join our email list, send us feedback, browse through the online store, and view our library of over 150 shows at gotohealthmedia.com. See you next time, and remember to elevate your life with Go to Health.